Welcome back to the Commissioner's Grand Rounds. We had a little bit of a hiatus for a couple of months, but glad to be back here. We should be proceeding on a monthly schedule going forward. As you know, the Grand Round series was my attempt to kind of just get us back together in community, but also talking about some of the salient issues that we face today in our field of public health, which is, everything's a little bit scrambled, isn't it, in the post-COVID emergency world? And so there's probably not an issue that I think is more important than the way we communicate our work to the public. Public health is grounded in science, it's grounded in strong values, it's grounded in a sense of collective and social responsibility, but all of it doesn't have the impact that it deserves and needs if we're not able to enlist communities behind us. And I don't know of another public health thinker, practitioner, expert, scientist that has done more on this issue than our guest today, Dr. Abdul Ed-Sayed, who is currently the Director of Health and Human Services for Wayne County Health, which is the largest county in the state of Michigan. Prior to that, he was the health commissioner of the city of Detroit. But you probably know him from his podcast, America Dissected, which is on a Crooked Media platform, and also ran for governor in the state of Michigan, which I was proud to assist him with on some small way. Ran for governor in 2018 and ran on a, number one, an unabashedly progressive agenda, but one that tried to take public health and explain it to people in ways that felt authentic and honest and, frankly, things you would vote for. So I don't need to do a long introduction. I met Abdul 15 years ago, maybe more than that, in medical school. And I remember meeting him as I was entering into the computer lab to take a test. And here was this guy standing out here, very, very sure of himself. And I was very focused on taking my test. And he interrupted me and wanted to talk. And I was like, I don't have time for this. I gotta go. But I'm so glad that I took the time, because not only is he a good friend, he's a role model and someone that I look to for guidance and support, but someone also has a lot to teach us about bringing the issues we care about, bringing health into conversation with communities, some of the opportunities to do that better, some of the challenges in our current environment in particular, and where that also runs into the current state of our politics, where progressive and centrist and right idealism is colliding, and where we're finding it hard to make smart, good decisions that protect everyone's health. So I'll stop there. We're going to do a fireside chat today because, I've known Abdul for a very long time, and it's much better to just see two people have a conversation. So join me in welcoming Dr. Abdul Ed-Sayed.
Thank you for the kind introduction, and thank you for taking that time right before your exam to sit down and build a friendship. I hope it's paid off. I have to tell you that it's been just an honor and privilege to watch your leadership and watch your career progress, and just grateful for the work that you all are doing here as a team, and an honor to be here with you all today. So looking forward to the conversation. Half my life I spend just chatting with people, so it's nice to be on proverbially the other side of the microphone. So.
Yeah, absolutely. And so I probably won't ask as incisive questions as you ask on your podcast, because I just have less practice. But let's start with an issue that's personal to you. It's on the top of everyone's mind. It's a source of great pain. And talk about it at multiple levels. And what I'm speaking of is the current war in Gaza, in the Middle East. Talk me through your thoughts on how that's affected you personally as a proud Muslim man in America in 2023, but also where does that collide with our values as public health practitioners, leaders, scholars, thinkers? what are our responsibilities to communicate around this issue? Where have we gotten it wrong? Where have we gotten it right? What do you see as the way forward?
He says he's not going to be incisive, but he pulls out the sword, right? But I really appreciate the question, and I want to start by saying that this is an issue that I know has been a festering wound for a lot of people. And if you grew up in either the Palestinian adjacent community, or the Jewish community, or Israeli adjacent community, this is something that you've consistently had to turn your mind to. And I want to acknowledge the suffering of civilians on every side of this, and certainly when 1,400 people are killed on a Saturday morning, that is terrible and ought to be condemned. On the same front, though, all of us come to this work because there is something about the dignity of a human life that has compelled us to leave all these other opportunities that all of us have had to be fighting for that dignity. And it's ironic, both you and I are epidemiologists. And there's something about epidemiology that always irks me, and that's that we take suffering and then we quantify it, as if tables can tell you how much suffering there is, as if you can quantify the aspirations of people who died, that are lost, and the hole that's left in their families' hearts when they die. And one of the frustrations I've had as we think about and talk about, yet again, this situation is the difference in whose humanity gets to be appreciated and engaged with in all of its tragedy in the moment of loss, and whose doesn't. And one of the frustrations I've always had as someone who's paid a lot of attention to the ongoings in Palestine is the ways in which statistics get used to grind down that humanity. 66 Palestinian children died today. Damn, like, stop for a second and think about what that actually means. 66 children had their dreams snuffed out. 66 sets of parents lost everything that they believed in and loved most of all. They had the lights turned off in their lives. 66 Palestinian children died today. And I think in this moment, what has made this so challenging is that even as we step up to condemn the 1,400 Israeli lives that were lost, I think it's also really important for us to step up and condemn the now 2,300 children's lives that have been lost, the 5,400 people overall whose lives have been lost, and to condemn that in the same humanity, with the same texture that I think is befitting of talking about a lost life. And when I watch as the institutions I'm a part of or affiliated with or have admired for a very long time miss that, to me, I see that as frankly, a willful choice to erase the humanity of people who've been taken away through a system perpetrated in large part by our own tax dollars. And, when I ran, and I still believe this, I don't think we should be in the business of A, spending as much money on our military as we do, and then B, spending money on other people's militaries. And that to me is out of principle. I would much rather be invested in people's healthcare, keeping people alive in institutions like this one, than I would be in institutions that underwrite bombing of people. And it's that willful ignorance or willful choice not to color in the lines on somebody's humanity that underwrites those policy choices in a pretty profound way, right? And that's what I've been really frustrated by. And at the same time, there are lessons for the work that we do. Because oftentimes when we do our work, we are in this, we use these empirical arguments, right, all the time. If you engage with X intervention, you save X number of lives, right? Or Y number of diseases prevented. And I think it behooves us to remember that the nature of humanity is that it's about those details that bring someone to life, right? It's about the things that are not just limited to boxes or squares or charts or graphs or pies, whatever it is. It's about the color in their lives. And our job is to bring that to bear. It's our job to bring that to bear when we're talking about lives in New York City, about lives in Wayne County, or we're talking about lives in Gaza, right? And I just think that, underlying all of it is that we stand for the dignity of people. That's what we do, right? And our job is to remember that and to apply that evenly, even when it's unpopular, even when power tells us we can't, Even when folks say, well, you didn't have to go all that far. Even when they tell us, well, this is the curriculum, follow the curriculum. This is not. You're coloring outside the lines. But sometimes there's a lot. It's important to color outside the lines. They still deserve color out there, right? And sometimes we miss that.
Thank you. Thanks for your honesty there. Really challenging situation, and it's a good segue to the broader reason you're here, which is to talk about public health communication. In order to color in those details, in order to tell stories, it's a skill. It's a skill, it's a discipline, it's a practice, the same way it is making life tables and graphs and line charts. And yet, public health has a lot of the latter and less of the former. So as an active sitting public health official, someone who's tried to take public health expertise and put it into words that the average voter or person could understand, and we saw again during COVID, communication was a huge challenge. What do you see as some of the key, let's say, gaps and challenges for public health? And what do you see as a way forward for us to start solving it? Because we have work to do. We have work to do on the way we communicate. I include myself in that. And I worry, as a field, we're not necessarily learning those lessons, particularly from the pandemic.
Well, I appreciate your attention to this, and I know that when you talk to the public here in the city, you really do try and color in those lines. So I appreciate you doing that. I just want to, because we're all, we'll just say, empirically driven people here, let me just share an A/B test of two different ways of conveying the same material, and just permit me an opportunity here. Let's say we go back like 1,500 years, okay? And there's a parent, and there's a child, and there's a well, okay? And the parent is here making a meal, and they see their child approaching a well. Parent has one of two options to communicate the inherent risk in the child's situation. One of them goes like this. Hey, Billy. Billy looks up, says, yeah. I don't know if you've seen the recent study in the Journal of Wells, but there was a statistically significant relationship between coming within 100 feet of the well and grievous bodily injury. Based on my interpretation of those findings, I highly suggest that you back away from the well. Okay. The other one goes like this. Hey, Billy. Yeah. Have you seen Danny lately? Billy thinks about it for a minute. He's like, no, I haven't seen Danny lately. And the mom says, well, the last time anybody saw Danny, he was doing exactly what you're doing. So when you see him, tell him I said hello. Guys, what happened to Danny? Fell on the well. And what's Billy about to do? Now, which of those packs a bigger bunch? B. Why? Because Billy had to think about it. And we had to think about it. He had an emotional reaction to the thing he thought about, which was like, oh, shoot, Danny fell down the well. And my parents are about to tell me that I'm about to do the same thing, and I probably should stop doing that. Now, there's all kinds of other trauma that can come with that. However, it's a much more effective way. Now, here's the thing about it. I want you to think about this. The first example was a very linear example, right? It was a very linear thing. Hey, we know that the risk of a bad outcome pending said exposure is high. Choose a better approach. The other one is, hey, you had to think through what happened to Danny, why it happened to Danny, and what that now means for you. But here's the thing about it. You'd think that this would be a harder process, right? It would be harder for us to process this movement of having to like impute what happened to Danny. But we, our whole lives, have been told stories. Stories are the natural way that we've communicated information throughout our entire existence. Why? Because empirical reasoning is a pretty new thing. Like before modern computing, it was really, really difficult to do any statistical analysis at scale. So most of the way you include information was just stories, right? I don't know, religious traditions aside, there's a reason religious traditions are communicated in stories, right? There's not like an empirical analysis around your like probability of going to hell if, right? It's like, here's a story, here's a parable for you, and you probably should pull out what happens in the parable. Now look, these are effective ways of communicating, whatever you believe about faith, right? And the point that I'm making is we spend a lot of time in our training learning how to communicate that first way. Yeah. And when I talk to students, I always say, like, you're in the process of being mismented, meaning you're spending a whole lot of time to learn how to think in an unnatural way, which is empirical reasoning, right? But we sit here and venerate at the altar of empirical reasoning as if that's how everybody thinks, even though we all have to spend, right, 6 to X numbers of years learning how to do it. And then we wonder why people don't appeal to empirical arguments. See what I'm saying? So what I'm asking us is this. There are two things we appeal to when we try to make public health arguments. The first one is authority, and the second one is empirics. And I think those two things are fine. But if COVID taught us anything, it's that we don't really have authority anymore, right? In a world of social media, people don't really care about the letters behind your name. They don't really care how long you went to school, right? And if anything, you show up and you seem like bureaucratically concerned, which is like the brand of our kind of concern, right? Most of the time, people are like, all right, what's your play? What's the catch here? And then the empirical arguments that we bring is like, but the science is clear, right? And then you hear this thing like, trust the science. The funny thing about it is, I just want you to think about the science for a minute. Science was created not to be trusted. Like, the whole point of science is replication. The idea of trust the science is like an anathema to what science is. Yeah? But we said, like, trust the science, as if we're the only ones who can be arbiters of the science. So our job is to translate what we do into language that most folks speak. So don't forget the individuals underneath the data. All right, so here's what we've found in the science. And I'm not saying not to be evidence-driven. Don't get me wrong. Like, let's be evidence-driven, of course. But when we communicate it, right, let's tell the story underneath the data, right? And I think that comes in two forms. One is, what's the story of the science? So, I was sitting here in my lab or in my research group thinking about, like, what causes this? And then I did this following thing. I did this test, and here's what I found. And folks want to understand what you found because there's a story here. There's characters. There's a plot. There's a twist. Yeah. So either tell the story of the empirical reasoning or identify the people in your data, which is to say, let me tell you about this one data point, right? Let's just say this person is like a 47-year-old, right, Black female. I want to walk you through what we found with her, like, and why that would happen. So I just want us to appreciate, like, there's a lot that puts us outside of the bounds of relatability for a lot of our folks, and our job is to put us back in there.
So let me press on this for a minute, because you used a word in your answer, the word emotion. And we've all been trained to take the emotion out of it, right? Whether you're a clinician or not, you've been trained to keep your emotion at bay or separate your emotion from the situation at hand. And certainly if you're a person who works with data all the time, keep your emotion, first look at where the data points, and then, contextualize it. We've also been taught that the emotion is now the greatest liability. We roll our eyes when we see someone reacting emotionally to our data. We roll our eyes when we see misinformation. We roll our eyes, but it is genuinely a reflection of some people's emotions around these issues, and our ability or inability to appeal to people's emotions, whether we agree with those emotions or not, to dismiss them, is in many ways a real liability for us, both to our authority, which has been undermined in other ways, but also to our long-term value proposition to people, because people now have other ways to find information and to make choices other than the edict of the New York City Department of Health and Hygiene or otherwise. So tell me about this issue of emotion. And you mentioned storytelling. Sure, storytelling is a vehicle and it's a device, but how do we all have emotions. We bring a lot of emotions to work today. I see it. And you all hold back a lot of emotions when you're at work too, as we all do. How do you tap into that as public health professionals in ways that are actually productive, generative, and bring people into conversation about what they need to do to protect their health and their communities?
Yeah, I really appreciate the questions. I'm gonna say three things. The first is, this is a George Bernard Shaw quote, which is I'm gonna get the quote wrong, but he said, the profound nature of modernity is the ability to weep at a column of numbers, which is what we do all the time, right? We look at this data and we're like, oh my God, it's awful. Most people are like, that's just numbers on a page. But we know what it means, right? Nobody here is here because you don't have emotions. Nobody, right? I mean, your pay is public. So is my pay, right? Nobody's here because you're like, man, I get an amazing pay. There's no way I can make that money out doing whatever else. You're here because you care. Caring is an emotion. The other part of it is, if you ever had a loving conversation with somebody in your family, if you just come up to them and be like, I'm completely emotionless, I really don't care what you do, but here's what I think. That's not effective, right? I mean, I really don't care. Like, I truly don't care, but like, here's what I think. You start with, hey, I love you. I want you to understand I love you. And the only reason I'm having a difficult conversation with you is because I love you. And listen, like, it's not my choice to make. And I fully respect that you're going to make your best choice. But I have to talk to you about this. Because if I didn't, I'd feel some kind of way, right? Third thing I'd say is that I'm a big fan of therapy, right? And one of the things they always say in therapy is it's not about doing away with your emotions. It's about understanding how they play. And one of the things that we kid ourselves into thinking is that we're so unbiased that our emotions are nowhere to be seen. Well, actually, they do come out. They come out in some pretty interesting and kind of weird ways. And so really, it's about understanding your own emotions rather than trying to do away with them. So there's this lie we tell ourselves that like we're like not emotionally compelled by any of this, even though all of us are here doing really, really difficult work because of those emotions. So my point is, it's important to bring them to bear and to understand how they play. So it doesn't, right, that you are truly trying to de-bias yourself as much as you can about what ought to be done, but then also leveraging that emotion to explain to somebody, to communicate with somebody about what ought to be done.
So let's think forward though, because, and I think we found ourselves as a field in a little bit of a defensive crouch here, right? Because trust the science has been the mantra. The science itself has been attacked, but public health is always at its best when it's the right intersection of science and society. And we seem to have, in a time of great attack and strain, leaned heavily onto what we can see and touch and maybe control, which is the manipulation of data. We can't control society and their reactions nearly as well. So talk me through your view on a little bit of a way forward for us as a field. We can start back with how people get trained in public health and public health communications. Why is public health communications its own field in and of itself? I'm not so sure, because I think communications is communication. But we've treated it as such. We've treated our communication as somehow separate. We run by a different set of rules, and that has to change. But tell us a little bit, and particularly for government public health institutions like ours, when people say public health's under attack, it's institutions like this that are under attack. It's institutions like Wayne County Health and Human Services that are under attack. So how do you think about this, both from a kind of thought leadership perspective, but also from an institutional perspective?
The question is a really important one, because it really should shape the way that we come at and engage ourselves and the broader community. And I'm going to go ahead and go all the way back to the very goals of our work. So I had a really interesting conversation with a professor at Berkeley named Jarrell Azell on the podcast. And he came to my attention because he did a talk about the public health swag gap. His point was that, like, we are just not very cool. We're just not, like, and I was sitting here trying to be like, yeah, it's true. Like, why are we not cool? And then you step back for a second and be like, what do people think is cool?
Says the guy not wearing socks and, that suit to this guy. So come on, dude.
So what makes someone cool, right? It's the risk of getting your ankles pulled. What makes you cool is risk, right? Just think about it. At the end of the day, what people are interested in, what makes someone cool is edge, right? And what is edge? Edge is risk. So like, think about the folks who are the coolest people you know. They just have this like never say die, come what may approach to whatever happens. The problem is, like, we're the anti-risk people. I mean, really, think about it, right? We are the anti-risk folk. Like, we're the ones who are like, you could do that, but. But let me tell you there's a statistically significant. So here's the thing about it, though, is that we weren't always that way. And part of the problem is we lost sight of what made us cool. Think about like the, the apocryphal Jon Snow story, founding of public health. I probably don't have to tell it in this room. Dude didn't just like do the analysis, publish it in a paper and be like, I know it's causing cholera in London. I wrote about it in the journal of whatever. He went and he petitioned this place called the Board of Guardians, which is kind of awesome. Like, I wonder what the individual guardian, they call it like a guardian. Anyway, he petitioned them at considerable risk to his own reputation and frankly, his own political well-being, because he had a truth, right? He didn't just walk up to people at the pump and be like, hey, you should not do that. He decided to take on power. And I think part of the challenge is that in the last 30 years, we have gotten a couple things I think have happened. We've got like hard science envy, right? So we can't run experiments in what we do. And the hard scientists are like, you're not a real science. We're like, we are a real science. Take us seriously, right? And so we just try really hard to be real scientists. And that leaves us in the situation where like, oh, we have to be unbiased, like the real scientists. I'm sorry, like I care about what happens out of our studies. I care a lot. I don't want the associations that we find to exist. Our job is to stop them from existing, not just to know that they exist. And so it's a matter of what you take on. So the problem is that was part of it. The other part of it is we got neutered. We let ourselves get neutered from being folks who took on power to being folks who told people about risks. There was a time when public health identified things and then went to the source of the power. Today, we take things on and then we like write nice pieces about what you ought not to do. And so like, I just think that part of what we have to do is go back to the source of what we did and realize that if we want respect, it is about taking on power. It's about being willing to step up, right, to the folks who are willingly making people sick, right, and wave our public health flag. And I'll tell you what, right, like at the end of the day, it's pretty cool.
So let me challenge you for a second on that issue, because I actually think this department in particular has led the way, Dr. Bassett in particular leading the way of naming racism and centering it in the work here. And yet, so often we are left to rhetoric on the issue of racism. So often we name it, and then when someone says, okay, so what do you want to do? Public health doesn't have the answer. Jon Snow had an answer. Turn off the pump handle. So how do you sort of square that circle? Because we are doing a good job of advocating for the issue of racial equity. This department, it does, at least certainly more than any other place I've ever been, to lift up racism as a public health crisis. But I find, I'm saying this very openly and honestly, I leave so many interactions wanting more solutions, more construction, more deconstruction, more leverage, and more action. And I don't have the answer. So how do you find the equivalent of turning off the pump handle for something that's a structural conceit like racism, which we cannot stop naming, but if we continue to name and not solve, our credibility diminishes over time.
Yeah. So I think, I want to be clear, like you guys sit within this department and it's important to be self-critical. Everybody else outside of this department looks at you all and says, all right, they're setting the standard. I just want to be clear. Like that's how people think about New York City public health. You're one of the few institutions in the country that is set up to be able to take on big fights and actually win them, right? And I say that for two reasons. So that you all, like, I don't want you to sit in this existential dread of like, we're not doing enough. Like, it's a very public health thing to be like existentially dreadful, right? It's like, oh, you're not doing enough. You guys are doing a lot, and that's like awesome, right? And you're doing a lot because you have the ear of leadership of other departments. The challenge often when we talk about racism as a public health issue is that we actually know what needs to happen. We're just not really willing to engage with it, right? So like, I'm gonna go ahead and put this out there, and what I'm gonna say, let me explain what I'm about to say. But like, the fact that if you are a Black American, you are 2 times as likely to be insured on Medicaid, and that Medicaid reimburses at half the rate is a truly profound racial justice issue. But here's the thing, when you say that, people are like, well, you're going after Medicaid? Don't you know that the right wants to cut Medicaid as it is? Don't you? I'm like, no, but like, I'm just saying that Medicaid should be as good, if not better, than any other insurance. And I'm actually saying that everybody should probably just have government health insurance, right? That's probably a thing everybody should have, right? Because like every other high income country in the world does that. But here's the thing about it. When you say that, folks will come up and be like, well, you're not serious. You're not a serious person. And the funny thing about it is it's like, it's actually deathly serious, right? It's a deathly, truly deathly, deadly serious thing. But sometimes we are pushed from that conversation because people say you're not serious, and we have a real fear of like not being serious people because those heart scientists over there can do experiments, that we're like, oh, okay, let me figure out something that I can do. And then we end up trimming our sales and trimming our sales and trimming our sales and trimming our sales to the point where I'm saying racism is a public health issue. And you're like, okay, so what? Right? So I'm just saying that like we actually a lot of times know what needs to be done. We're just cowed from saying it. And I think that like it's just really important to step up and say, okay, we're going to get everything done when we can, right? But let's not forget that the fundamental setup here is broken, and we're not going to stop saying it, right? And that's a hard thing to say, right? And it does mean that sometimes people are going to try and marginalize you. But I just think that it's important to keep on saying it because that's how things move. So I think it's two parts. You guys are doing an amazing job here, moving the conversation about racism and public health into other spheres in which it matters, right? Whether you're talking about law enforcement, you're talking about housing, you're talking about air quality and water quality, right? These are all things that really, really matter. And that's really important. That's how you take on the public health challenge of racism. But it's also about saying, boom, that's the site. And we can't stop saying it. You see what I'm saying? And I'll be honest, like in this, I only speak for myself here. I just put it out there. I do not speak for the New York City Department of Health and Dental Hygiene. I do not even speak for Wayne County's Department of Health and Human Services. But let's be honest, right? Let's be honest. At the core of America's health challenge is the fact that we spend nearly a fifth of our entire GDP on healthcare in a system whose mission it is not to care for people. No, like if you just look at the decisions that are made, the mission is to profiteer off of sick people's bodies. That's the mission. And until we talk about that problem, what's going to happen is who tends to get the most healthcare? People who need it least. Who tends to get the most? Now you'll probably say, well, that's healthcare, not public health. 19% of GDP. Think about where in another world we might get all the funding for public health. Maybe it's the excess money we spend on unnecessary healthcare while Xing out all the people who need it most. And guess what? Structural racism tells us that the people who are going to need the healthcare most and get it least are going to be Black folk, right? And it doesn't just show up in who doesn't get healthcare. It shows up in what kind of healthcare people actually get when they get in the door. If you are a newly pregnant Black mother, right, your experience of the healthcare system is it's always trying to kick you out. And everyone's like, well, why don't they use prenatal care? What do you think? Right? Like when your experience has always been people implicitly telling you don't belong here or you're a second-class citizen because your reimbursement is half as much as everyone else, what does that tell you about who you are? About who's going to give you healthcare? About whether or not you can trust this person who can't really bill against your Medicaid? So we don't think about it that way, but that's part of the issue. And I just think it's worth us asking, what can we do where we are with what we have? And you guys are doing that. But also, how do we not pull our punches about what's happening, right? About how things could be, about how things ought to be.
Well, so this is a great, you said, what can we do where we are? Because the conceit you raised, and what's so brave about what this department has done is set a goalpost, right? Just put a stake in the ground 10, 12 years ago, right? We said, we're going to center racial equity in our work. Not knowing exactly the path of how this department or anyone else would actually build into it. But 10 years on, I think what we find ourselves in is a moment where there are enough people saying, well, you're not serious because you're just advocating. So where do you see the role of the Wayne County Health Department, the role of the New York City Health Department in continuing to not pull the punches, as you say, which is advocacy, but building into the space that needs to be the pump handle, right? Yeah. The actual work, because whether you take the issue of racism as a public health crisis, or even take the issue of pandemic response, we will get relegated back to that. Well, racism is a public health crisis. The nanny kind of wagging of the finger, rather than, oh, you know what, we've got constructive solutions on how we're going to fix this. So what is your For government public health workers, which we are public servants. Teachers pay our salaries, doctors pay our salaries, delivery workers pay our salaries. If we want to be advocates, purely advocates, we could do that elsewhere. But we have the tools of government at our disposal and all these resources and the incredible thousands of staff in this agency to work with as colleagues. So tell me how do you see the unique role of institutions like this and the institutions like the ones you lead to not fall into the traps of just naming it and not filling in the white space?
Yeah, it's ironic because the argument they make is you're not serious people. They don't know us. We're really serious people. And I think being serious means putting solutions in the ground. So the way I think about it is if you imagine where we're trying to get to as a destination, an island that's separated by a body of water, right? You all can imagine that well. In New York, we've got a bunch of lakes, so you can imagine Michigan. And our job is to build bridges. And we may not build the whole bridge in one go, right? But we can definitely build the foundations of it. So the way we've thought about it in Wayne County is to say, when we get funding that we can leverage to address some of these broader issues, the way I'm going to address you saying that we're not serious is to demonstrate very, very clear competence in the direction that we need to go. Now, is that going to solve the whole problem in one go? No, it's not going to, right? We don't have the funding, the circumstances in our society are not such that we can get all the way, but we are going to do everything we can to get there, to undercut your argument, right? Whoever you are, that we're not serious people, right? And so to me, it's chunking out the broader challenges that we face and creating micro solutions in space.
What's an example? What's an example you can give us?
So in our county, we've got a zip code called 48217. 48217 is the most polluted zip code in the entire state of Michigan. And that is a function of structural racism meets environmental injustice. And that means that folks who live in that community have the highest rates of asthma, the highest rates of lung cancer in the entire state. Now, technically, we as a county have no jurisdiction when it comes to air quality questions. And I love it. The state will always lecture me, like, you don't have jurisdiction here. But like, okay. So what I'm going to do is I'm just going to build, right, a system of air quality monitors that is leveraging data to move it to families with children with asthma, families who are vulnerable, so that they know what the air quality in their local community is. And the next time so-and-so company applies for a permit to allow them to put yet more poison into the air, we are just going to have a whole lot of data, right? And we understand that we don't have jurisdiction, but I'm really lucky to work for a county executive who cares a lot about whether or not kids can breathe clean air. And so we are not going to be able to decide whether or not someone gets a license, but we are going to be able to raise a ruckus about whether or not we think this is a good idea. And we're going to challenge you to go ahead and authorize yet another higher rate of whatever the poison is, sulfur dioxide, whatever it is, that this company wants to put in the air. And we're going to let you and your elected officials deal with the noise that's going to come out of it. So you're right, I have no jurisdiction. I just happen to be curious, happen to be interested and very interested in data. Like, who doesn't want more data, right? Huh? So the point that I'm making here is that, yeah, we're not going to be able to change jurisdiction, not yet. But what we can do is build out a set of solutions that holds polluters accountable, that uses the system to make an argument, and in the process, probably most importantly, gives helpful information to families who could use that information to protect their children and seniors in the process. So that's one example. Another example, we know that we have extremely high rates of high school and college dropout, particularly in folks who've had children before they've graduated. And so one thing we're looking at doing is just building a program where we can offer $500 a month for a young parent who's enrolled in a community college who also has children. And that buys them out of the choice of, do I study, go to class, work, or take care of my kid? Which I kind of have to do all of them. And so we can make that just a little bit easier for you. That's fantastic. Now, a lot of folks would say, well, that's not traditionally public health. I don't know. I think if mom or dad can finish up their associate's degree and they can get a better job and they can afford more consistent food access in the home and they can change the trajectory of baby girl or baby boy's life, I think that's a public health issue, don't you? And so my point is that these are ways of taking this issue and saying, how do I make a program that's accessible to everybody that will disproportionately take on the inequities that exist in our community and do so in a way, right, that takes on an innovative approach to what public health traditionally does and thinks about it in a slightly different way, right?
So how do you think about that in the context of a place like this, where we are not a human services agency? We don't run a lot of those benefit programs, that those are run by other agencies. You mentioned data as a storyteller, data as a convener. How do you see the role of, we are an expansive, incredible public health agency, but we are also narrow in the sense that our healthcare footprint is limited, our human service footprint is limited, and we do a fairly narrow set of things. If you think about it in terms of the apparatus of everything that affects public health.
Yeah.
So how do you think about the role of kind of traditional public health agencies like this one versus, county or state public health entities that have more of the apparatus of payment and revenue, Medicaid offices, for example, at the state level, or in your case, local benefits? How do you think about, because you have a very clear way of telling the story of how that payment will make a difference in short and long-term health and decision-making for a family. We don't have that apparatus necessarily. We do build pilot programs and we do some cash transfers and work like that. But tell me how you think about both the strengths and the limitations of a place like this.
So I got to brag on your commissioner here for a minute. He didn't pay me to do this, I promise. But if you need my address for the check, it's fine.
Then
He's one of the best coalition builders I've ever met. Truly one of the best. And if he has many, many amazing skills, but if he has one superpower, it's being able to have very effective conversations with people who don't come from our world and don't necessarily see things the same way. And I'll be honest with you, this is going to be like an anathema, so please don't boo me, like throw tomatoes, whatever. I think the term social determinants of health is like the worst thing we ever came up with. Can I just explain why? Because like half the time when public health people talk about social determinants of health, we all walk up and someone's like, well, that's a social determinants of health. And everybody shakes their head and walks
so I couldn't have gotten it tattooed.
Yo,
Steel Age for life.
And the problem with it is like we have this sort of fetish, if I may, of like using really big words to explain pretty simple ideas, when actually like real intellect is using small words to explain big ideas, right? And so, but the thing about social determinants is that it created this sort of like expanding scope for us where we sort of like, we almost, I hate to say it, but like we almost give up on the like little things we do every day. Because they're like, well, it's not the social determinants. Like we clearly have to take on poverty and racism. Like we're gonna do anything here. The thing about it though is taking on poverty and racism is about coalition building outside the bounds of your own department. And so the ability to sort of bring together stakeholders across a civic space like this one, in a city as large as this one, right? That is the work. And it's two things. It's all of the work that you all do every day to run your programs extremely well, right? And the other part of it is, it's about leveraging that capacity to address, I'm gonna use a very complex term, I'll explain what I mean, the inherent moral hazard in partnerships. See what I'm saying? So like, if you decide that you're gonna meet somebody for dinner, you take a judgment about like, how likely are they to be on time, right? And moral hazard is what happens when you're like, all right, we're meeting for lunch or dinner at 8:30. And then you know that you're gonna text at 8:29. And that person will be like, sorry, I'm so late, big train, I swear, right? And then they don't actually get there until 9. That's moral hazard. The way you address moral hazard is you assess, you take an internal assessment of who this person is. So you know, right, like who your friends are going to be late and who your friends are going to be like 15 minutes early, have already made a decision and ordered for you, right? Now, moral hazard is addressed when Ashwin goes and has a conversation with, you name the commissioner, right, of whatever other department, and they're looking in and saying, okay, we want to build this partnership to take on the social determinants of health. And they're like, all right, like how good is DOHMH at actually putting up their part of the bargain? And every day you all show up and you do your things in an excellent way, that empowers him and everyone else at the top of the department to go out and build those relationships. And one thing I'm gonna tell you about how government works, I've led 2 health departments now, is that there's this leadership saying, and I don't think it's quite equitable. I have a lot of issues with it, but they say feed the sharks, starve the minnows. It's a terrible way to think about the world. But a lot of times when elected officials are thinking about where they want to invest, that's how they think. And so when we show up in departments like this to do the baseline work we do well, right? And all they ever hear is like, oh, I interacted with the Department of Health today and they're phenomenal, right? They were so professional. And like every time I ever interact with them, they're amazing. When they hear that, they're like, when I'm putting together a budget for next year, I'm going to feed the sharks. See what I'm saying? So when he goes up and says, I have a really great idea, and here's where I think we need to move, and I'd like to bring on these other 2 departments, it's more likely when you all show up and do what it is that you do every single day with a level of excellence, right? And a level of customer service and a focus on what it is you do, even if it's not taking on poverty and racism directly, it means that he can go up and say, I need X million dollars for this program. And folks are like, if I give him X million dollars, it's going to show up, right? This is going to create an awesome program. So I just want you all to think that through, right? Because sometimes we say, well, if I can't tackle those other big upstream determinants of health, then what am I even doing here? Well, you're creating the bureaucratic reality that empowers leadership to go out and fight for exactly those programs and those partnerships. And that really, really matters in places like this. You've got an amazing coalition builder who is already doing that work, but it's on the whole department to show up to do what we do well, right? To be able to empower that outcome.
So tell me, thank you, I will send you. Tell me though, I know we're sharks, you know we're sharks, but the rest of the world sees us as minnows. Not everyone, not universally. I know it's all relative, right? Wayne County versus New York City, but I'm thinking, yeah, come on, guy. But no, really, we're in a world where public health is being increasingly treated like minnows, and yet stepped up to face this massive pandemic in really heroic ways. What do we need to do in-house? I always think about problem sets as the part you can control and the part you can't control. And we spend a lot of time thinking about the parts we can't control. But there's a lot we can do and a lot we can control. What are those issues as you see public health departments going through the sort of picking up the pieces of the post-COVID emergency or post-COVID world and trying to reckon with its future, whether it's yours or ours, or more generally, as you see the CDC, how do you think about that? And what are your priorities as you think about what you would focus on if you were in any of those roles and the one you're in?
Yeah. So if you want to be a shark, show up like a shark. And I just think there's a certain level of confidence in the way that we engage and what we do that itself matters. And I hate to say it, but like, we show up, right? We talked about being like existentially anxious. We show up as existentially anxious in what we do all the time. It's like the way we're so self-critical to the point where it almost undercuts any confidence in what we do. And I just think we have to get past that. What we do is really important and we do it really well, right? The second part of it though is also about like where we started this conversation, showing up and communicating, constantly telling our own story, right? I think there's this, both of us started our careers in academia. And it's a really good metaphor for us because we think that because we've published a thing, that everyone has seen it. Nobody's seen it. Nobody cares. Like nobody read your paper, right? And I think the faster you come to grips with that, the faster you start to realize that you've got to constantly be promoting the work that you do every single time, right? And I think sometimes when we show up, we think what we do is self-evident. It's not, right? And in a world where attention is literally the most valuable commodity, it's really difficult for people to show up and try and figure out what we do. I mean, I want you to think about this, right? Like the biggest tech companies in the world trade on what? Time on your eyeballs and your eardrums. That's it. So we're all competing with them, right? And we're just not as interesting as the latest TikTok dance. So maybe we should try, right? Like really, like this is my point, right? It's like you may not be able to compete with it, but maybe we should try, and we should probably not be ham-handed about it. Like there's this way that sometimes we show up like, hello, fellow youths. Don't do that, right? Just like be you, be the most compelling version of you can be, and keep showing up and being consistent, right? So when I ran for office, anyone will tell you the most important thing as a politician that you can get, right, is attention, and it comes in a couple ways. People should be compelled by your message, and you should always be on message. So always be on message. This is who we are. This is what we do. This is why you need us, right? And this is why we're so glad to serve you, and do it in a like compelling, interesting way, right? And I think if we did a little bit more of that, what we do is self-evidently important. We just don't really brand it, right? So like people will use our services, and we're totally okay with them just being like, all right, I want the health department. Don't tell folks about how amazing it was, right? Tell folks about your experience here, and let's then work to make it the best possible experience it could be, right? And when folks interact with us, then they're like, hey, that was a great experience, and those folks are kind of great. And I just think I hate to say it's as simple as a change of attitude, but sometimes it's really just a change of attitude. What we do is self-evidently important. We put some emphasis on branding what we did in a consistent kind of way. I think it would really benefit us.
Yeah, and we're taking some steps in that direction now. It is an interesting time because health is very self-evident to people. But somehow public health has become separate from health. And we have to work we need to be the arbiters of health, whether or not we deliver on it. If we're telling the story of health, of the health of New York City or Wayne County or the United States, it should be coming out of the voice of places like this. And for a time during COVID, it did, right? Because people looked at our data, and it was singularly the data that they went on every morning checking our website. And so when I think about the things we're doing around data and communications and the investments we're making there, I think of those things as all about the mouthpiece of telling the story of the amazing stuff that everyone does here every single day, but is invisible to most people, is invisible to most New Yorkers, who, again, pay our salaries, right? I mean, they pay our salaries every single day. So I want one last question, and then I want to make sure there's time for at least a couple of audience questions. You took the decision to do a podcast, and in that podcast, I've been lucky enough to be on your podcast in years past. Tell me what that experience has been like. How have you gotten better through it, and what could we all take from the experience of being in conversation with people in the way that you are, in the way that we are right now?
So I spent a lot of my career before I hosted the podcast on the other side of the microphone, right, being the interviewee. And a lot of what I tried to do was like, I need to move my message. I need you to get what I'm saying. I didn't really appreciate how important the questions were until I started asking them. And if the thing I try to do is to sort of be the setting to a beautiful diamond, right? We want great guests, right? Like your commission. But we want to set them up to be able to tell a story, to capture what it is they do in the best possible way. And I think one of the things that became clear to me on the other side of the microphone, especially considering the fact that it's a competitive business, you're always interested in getting more downloads. By the way, if you're not subscribed to American Secondary Show. Anyway, but the point is also trying to connect to what is it that my listeners actually want to hear about, and how do I feed them, right, a dose of the message I want to communicate, right, dressed up in a beautiful setting, right? And so there are things I want folks to understand. And the interesting thing about our podcast is there's a lot of listeners who are public health people, right? And they tune in for conversations about public health. And what I try to give them is a way to talk about these things so you sound like a normal person, right? For the folks who show up who are not public health people, I want to teach them some things about public health. So you may be coming for a conversation. We just did an episode, came out today, about mosquitoes, right? But I want you to be thinking about, well, what's the trade-off between a genetic approach where we modify a bunch of mosquitoes so that they fail to thrive? What are the knock-on effects of that versus just investing in screens in people's homes, which is a much more public health approach, right? And I want folks to have to think about some of these approaches. Do we believe that biomedicine is the answer to all of our problems? Or are there ways for us to be investing in prevention on the front end? Who benefits from that versus who benefits from the other? Who are the actors in our world who are making money off of our illness? And I want you to see them when you start thinking about the world. So there's a broader curriculum that we're trying to develop in language that you come in for an interesting conversation about mosquitoes and you leave being like, I wonder why we're always doing these things and not doing as much of these things. You know what I mean? And I guess as you think about, your engagement, just remember that you are part of a conversation that is happening around you. And I think sometimes we're so stuck in our own bubble that we assume that everybody's part of our conversation. They're not. Most people are not part of the conversations that you have here. So you have to create an accessible conversation that brings folks in where they are and feeds them a little bit. The last thing I'm gonna tell you, right? If you take nothing else away from this, right? A, it is a truly good decision not to wear socks. B, if you tell people everything, they remember nothing. If you tell people something, they remember something. I think we try and tell people everything. And part of that is our own insecurity that people might think that we don't know. So we're like, well, let me tell you everything I know so you know that I'm a credentialed expert in public health. Okay, cool. If you want people to think you're a credentialed expert in public health, that's one thing. If you want them to understand or learn something, that's another. So boiling down the message and maybe missing some of the nuance or the details, that's okay. As long as folks leave, A, understanding something, but B, wanting to learn more. Right? Think about the best teachers you ever had. They weren't people who are just like, I'm gonna implant information in your mind. They were people who made you want to learn it because they were like, this is so compelling and you're missing out. And you're like, I guess I am a dropshipper. So try and be that, right? One piece of really important information compellingly, where you're communicating that infectiousness, that interest, that curiosity, and folks are like, where can I learn more? If you leave them wanting to learn more, that's the one.
Very good. And a good way to end. I do want to make sure there's time for audience questions. I'm sure there'll be a few. Are we?
One question.
Who's here from mine? Should I just hand this in? You can hand it up.
I would say we have time for one question.
Only one? Okay.
Yeah.
Let's do two. We'll make it next section.
You did a good job of, answering some questions I had when we submitted. But you didn't tell me what's going on in Wayne County and southeastern Michigan, which is my home. I want to know, how do you interact with Beaumont, Henry J?
I think it's great. And
Ford.
Wayne County's the best place. Next to New
What is going on, with Detroit Medical Center, since you are that person at Wayne County?
Yeah.
How are you interacting with, because everybody can't have a Beaumont doctor.
No. So I think I'm really lucky to work for leadership that is truly committed to the well-being of folks in our community. And that shows up in, we got about $338 million in ARPA funding. 60 million of that has been put aside for health. So that's allowed us to really think outside the box about some of these innovations. The point that you made about healthcare, I think, is a really important one. And we're right now in the process of trying to, as you all already did, wipe away medical debt, which has meant that we have to work with area hospitals. And one of the things that's happening, we can get down in a whole conversation about consolidation, is that Michigan's or Southeast Michigan's healthcare environment is very, very rapidly consolidating. And I think this might be one of the most dangerous things about current healthcare, because what happens is there's this concept called monopsony. So you all know what a monopoly is, right? There's one seller of a good. Monopsony is when there's one buyer of a good. And usually when we talk about monopsony in economics, what we're talking about is the labor market. So when you have consolidation across a number of hospitals, you go from having 10 hospitals in a county to having 3 hospital systems. Those hospital systems can collude around what they pay employees. And so you see this relative decline or flatlining of what folks who actually work in healthcare will make. In response to that, though, what has tended to happen is you're seeing a lot of union organizing, and that's happening. Nurses got there way long ago. Hospital employees for the SEIU and others got there a while ago, but you're also seeing physicians start to organize, which is something that nobody ever saw coming. And that's largely because of this consolidation. So we've been having conversations with these increasingly consolidated units. So Beaumont doesn't exist anymore. It's now called Corewell, which is like a name that you only cook up in some consultant's office. Like they're like, well, at the core, fantastic, Corewell. It's like you the whole time. And then Henry Ford and Ascension, which used to be St. John's, just came together in one like mega system. So you now have Henry Ford Ascension, the DMC, which is now a for-profit system, and you have Corewell. Lots changed. So these are dynamics that are happening across the country, and they're really changing the way that we can interact with the healthcare system. So I appreciate the question and love to talk more about it with you. It's an interesting, very dynamic moment.
Okay, last question.
Hey, yeah, it's a comment. I think there's a question in there, but to the earlier part of the conversation around what can we do or how can we move forward? I'd like to offer a framing of health equity as this intervention, right? I think we often kind of look at it as pie in the sky or all philosophical, but when we look at what's going on in the medicine that we practice to our own imaginations, it's held captive by this concept, this mental model of white supremacy, right? When all of the things that we talked about that are in the way of how we communicate, it boils down to this cultural way of doing things. So health equity, the way that we talk about it in the Center for Health Equity, Community Wellness, we talk about it as an intervention, as a way to see things different, as a way to act different, as a way to create programs different. And in the last few years, we've seen this intervention work, from COVID, closing vaccination gaps, from MPOX. MPOX in New York City we were the epicenter, and we saw a kind of traditional approach that didn't meet all of the things, but when we took a more equitable approach and really leaned into that, we were able to do amazing things and really stop that. So I think when we're looking at ways to kind of move forward, I really think that we should really emphasize health equity and what it does do as a bridge between the public and public health. It helps the public see themselves in healthcare, how so often they're not included, they're not even considered. We have to stop seeing people who are called marginalized as marginal, and I think we have to really look at the work of health equity as a very serious thing, decades of work. It connects us in public health to these other social movements. It connects us to these other ways of thinking, philosophy, all these other things. So I think that one of the things that I am advocating for, and I think it kind of comes from you, is to really reimagine and look at health equity as this intervention and a way to move forward that can really instill our, a sense of trust and rebuild, and I guess ending to acknowledge and respond to the insult behind the injury. Because being marginalized is an active process, it's a painful process, it's an emotional process, and health equity is one of the only, realms or areas of work in public health that we can actually hold that emotion, that we can hold these truths, multiple truths at once.
I really appreciate your comment and question. And the way I understood what you shared is that this is the framework that should advise us about how we intervene, not just on the direct, tangible, technical aspects of the work, but also on the processes that yield the kind of inequities. And I also think what you shared is that we tend to think about health inequity as a state of being rather than a state of doing. And I think that's really important. One note I would say is that how do we talk about health equity to folks who may not understand what we mean, particularly when we use that language? And that's been one thing that I've really tried to challenge our team to do, is that we know that equity is at the heart of what we do. We hired our first ever chief health equity officer, who's also the deputy director of the department. And we try and bake it into everything we do. But part of it is when we talk about health equity, it's really important that the folks that we're centering understand what we mean. And I think equity is there's all kinds of conversations about what it means. Is it equity or equality? Are we talking about processes? Are we talking about resources? Are we talking about outcomes, right? And I actually think we just need a better way to talk about it that doesn't center a word that has different meanings to different people. Because I think if you talk to my folks who are immigrants and have the privilege of education, if you said, all right, you got what is equity? They'd be like the amount of something that you own, right? That's equity. I've got equity in so-and-so. And so I think partly what I've tried to do is to say, you also matter. And too often our system tells people they don't matter, these people. And what we're really trying to say is the folks that we're trying to center is that you also matter, right? It's not that they don't matter, it's that you also matter, right? And because you also matter, here's what we need to do. Here's how we're going to address this issue. Here's what we're paying attention to. See what I mean? And I think the point that you made is a really great one, which is to say, this is about process. And I think sometimes the mistake we make here is that sometimes we forget that the jargon we use itself is marginalizing. You know what I mean? Because we spent a lot of time learning and debating what it actually means. And the more that we can make sure that our language is truly inclusive, right? Small word for big ideas, the more effective I think we can be at engaging people as a force for their own liberation. See what I mean? And I think sometimes we miss that. Like, we are going to deliver here for you, rather than saying, actually, you're the folks who are going to deliver. You tell us what we need to do, and we're going to do our best to deliver. I really, really appreciate your comment and your leadership. Thank you.
Thanks, Julian. Great question. And let's just give it up for Abdul.
Thank you for letting insights in it.
Yeah, I think you're gonna take over the podcast.